So, Yogi, could you say something? I just want to make sure that your audio is working now.
Okay. Good morning or good afternoon, everyone. Good morning from this world.
Good.
5 o'clock. Can you hear me?
Yes, it's
Okay.
working, Yogi.
Okay, great. Thank you.
And so, yeah, I want to wait till we have Soumya before I do anything more. And Zen, because those two are going to be key as the first couple of people.
Mhm.
Camilla, where are you right now?
Me?
Yeah,
Lima,
where?
Lima, Peru.
In Lima. Okay, very good. Everybody seems to be in a sunny place except me. I see sunshine for everybody. Neil, where are you? Because I should have the same weather as you.
It's Waterloo, Ontario. So
Okay, well, I'm downtown Toronto. We have less sun. Okay.
yeah. And so Soumya is here. Just want to make sure, Soumya, could you say something just to make sure that things are working? I think I'm going to just text Zen.
Yeah. Hi, Neil. Hi. Can you hear me okay?
Yeah,
Yeah.
perfect.
Have we haven't opened to the participants yet, is it?
Oh, we have here, we aren't expecting, I'm expecting maybe 10 people outside of us. This is primarily for recording for the Institute, Soumya. So I know you might be used to speaking to hundreds, but this is primarily really for the future for planning activities. So really appreciate having you here.
Okay.
So I'm just gonna text Zane, and then I think that maybe we'll just get started because I know Soumya has to leave very soon, and then we also will have Divya coming on in the next little while. So just in the name of time, we'll just get started. I'm Neil Arya. I'm the chair of the Pegasus Institute for Peace, Global Health, and Sustainability. This is an organization that's been around for a year, but we've had a conference, the Pegasus Conference, since 2014, and now it's recently formed as an institute. You can find out more about the Institute and also previous videos of roundtables and webinars that we've had at www.pegasusinstitute.ca. We begin each of our sessions with an acknowledgement. And while we're gathered here virtually today, we acknowledge that each of us is on the traditional territories of many nations across Turtle Island. I'd like to acknowledge that I am on the traditional territory of the Neutral, Anishinaabe, and Haudenosaunee peoples on the Haldimand Tract, land promised to the Six Nations, which includes 6 miles on each side of the Grand River. And on the screen, you have that from Toronto. We offer this acknowledgement as a stepping stone towards honoring the original occupants, a testimony to the oppression faced by Indigenous peoples, and our commitment to creating dialogues aimed at addressing systemic injustice and equity that Pegasus engages in, such as this discussion today. Dr. Soumya Swaminathan, Zen Chugla, Carrie Bowman, Camila Janela, Yogi Chaudhary, Srinivas Murthy, and soon to be Dr. Divya Santhanam are going to be joining us today, giving different perspectives. We'll have an introduction to the world and Canadian situations with regard to COVID and vaccines, an ethical framework that'll be presented, and lessons from arguably perhaps the hardest hit country in the world, Peru, and the least hit thus far, the Solomon Islands, before we discuss issues of compulsory licensure and advocacy. After the introductory remarks, we'll have an intra-panel discussion before opening things up to more wide audience interaction. And I see that, as usual, our audience tends to be people who have great expertise. So, so I can move us ahead of schedule. I'll just begin with Dr. Soumya Swaminathan, who was appointed WHO's first chief scientist in March of 2019. A pediatrician from India and a globally recognized researcher on tuberculosis and HIV, she brings with her 30 years of experience in clinical care and research. Dr. Swaminathan was Secretary to the Government of India for Health Research and Director General of the Indian Council of Medical Research from 2015 to 2017. She's published more than 350 peer-reviewed publications and book chapters. We have a little bit longer bio on our webpage that you should be able to get to. But Soumya is going to give us an update on epidemiology, talk a bit about variants, vaccines and boosters, including global vaccine status, and equity as it's seen from a WHO viewpoint. So thank you, Soumya, for starting us off. And I know you'll have to leave a little bit sooner than some. So, but we really welcome you being here. And thanks for coming later in the evening.
Thank you. Thanks very much, Neil. So maybe I can start with the latest epidemiological update, which basically we track on a daily basis because of the reports that come to us from all member states. And last week, I think it's a 6th straight week, maybe even the 7th straight week that we've had a decline in the number of cases being reported. So 2.7 million new cases and 46,000 deaths during the week of 11th to 17th October, which was similar to the previous week. So it's not really reducing very rapidly, but at least it's not going up. The European region, you know, we have 6 regions that we look at. The European region reported a 7% increase in the number of new weekly cases as compared to the previous week, but all other regions reported declines. And the largest decreases were seen from the African region, 18% decline, and the Western Pacific region, 16% decline. So the cumulative number of cases, confirmed cases globally, is over 240 million. And the cumulative number of deaths is now getting close to 5 million. Now, remember that these are only reported cases. And the seroprevalence studies, which we've been tracking, you know, we had quite early on in the epidemic, in the pandemic, had launched a set of studies called the Unity studies, which basically provided a standard template for countries to do seroepidemiological sero surveys. And one of the important elements was standardizing the assays and the laboratory standards to be used, because, you know, that if that varies, and it does from study to study, then the results are also not comparable. So we've been tracking the seroprevalence studies as well as done within the Unity framework. Countries have done on their own, different quality, of course, varying quality of studies, but essentially what it shows is that in some regions of the world, you had 85% basically of cases being undetected. Africa, for example, 5 out of 6 cases are not detected. And this is because, again, we can come back to it on the equity issue, but equity is not just around vaccines, we talk about it, but also around diagnostics. And if you look at the access per 100, you know, population for diagnostics, I can give you the numbers. It's also quite stark. So that's why reported numbers and reported deaths are not telling us everything. And we also cannot compare countries. For example, in the US, it's, I think, expected that 60% of cases are detected. but in some countries, it could be less than 10%. Similarly for deaths, those undercounting of deaths is also very variable, and it's happening everywhere. And there have been varying estimates. WHO estimate of 2020 was that deaths were undercounted or underreported by about 2 to 2.5 times. So essentially, we're looking at a huge toll in terms of morbidity and mortality. We also know that COVID infection often leads to long COVID, post-COVID symptoms. We recently came up with a definition, a consensus definition of this condition, a long list of symptoms and signs that people suffer from. And so it's also chronic sequela. It is estimated that the pandemic has already led to a loss in global GDP output of over 9 trillion. And I think recently the IMF came up with a estimate of another 5 trillion loss in 2022 if the vaccine inequity persisted, and that if large parts of the world were still susceptible to the infections. In terms of the variants, again, something we've been tracking from June of 2020, thanks to all the databases that are available where people have been submitting their genome sequence data. And it was towards the end of 2020 that we really started seeing, or countries started documenting the fact that certain variants were very different in their characteristics. And the characteristics we're interested in are transmissibility, clinical manifestations or severity. Does a variant cause more severe disease, leading to the need for hospitalization? And thirdly, what happens in terms of the efficacy of vaccines and naturally derived immunity in terms of variants, and we know now that of the 4 variants of concern, alpha, beta, gamma, and delta, that delta variant is at least 3 to 4 times more transmissible than the original Wuhan strain of the virus, and that also it has partial resistance to the antibodies, in that not only does it overcome natural immunity more efficiently, but it also needs a higher level of neutralizing antibodies in the blood. And many studies around the world that have looked at vaccine-induced immunity have shown that compared to alpha, the delta, and compared to the original strain of the virus, the D614G, that the delta strain actually has is less susceptible to the antibodies. So we continue to track variants of interest as well from around the world. And of course, there are all of these different combinations of mutations. So what we need is the systematic kind of studies to be done before we can classify them as a variant of concern. And so one of the things, again, that was observed was that genomic sequencing capacity was variable, and that large parts of Africa at the beginning had very limited capacity for molecular diagnostics and very low capacity for genome sequencing at scale. And so over the last 12 months, many agencies, including WHO, have been working to strengthen that. And today, of course, it is a little bit better, but still, if you look at the volumes that are being deposited in a database like GISAID, you'll find the majority of these coming from Europe. Even North America hasn't actually done so well. It's the UK, Europe, and then countries like India, China, etc. And from Africa, basically South Africa stands out as the one country which has the maximum amount of research capacity, including genomic sequencing, and that's been able to really share a lot of data. We also have something called the COVID Clinical Database platform, which currently has about 400,000 patient records. So some of the things that happened during COVID, I think, are very positive in that there was a lot of willingness for global collaboration and willingness to share information without waiting in the traditional sense for publications and so on. So the COVID database, clinical database, these sequence databases, as well as the prospective meta-analyses that we were able to do with several investigators doing clinical trials, looking at the same drugs, we engaged them proactively to take part in prospective meta-analyses so that evidence synthesis could be done and recommendations made in a timely manner. Obviously, there's been a lot of work in the research side that, again, WHO was quite involved with right from the beginning of coordination through the R&D Blueprint platform, came up with a research roadmap in February of 2020, and then have basically continued to engage with not hundreds, but thousands of scientists around the world, all organized into different working groups, advisory groups, etc., looking at everything from animal models, standardizing them, standardizing lab assays, to clinical trial design, looking into immunogenicity studies, collating the evidence, and also beyond product development. So we've had groups looking at ethics of different aspects of the pandemic, and they've come up with a series of papers which have been, I think, very, very interesting. Ethics of human challenge studies, the ethics of contact tracing apps, the ethics of mandatory vaccination, a few examples of issues that have come up during the pandemic. We've had groups working on infection prevention and control. Again, a lot of, I think, improved understanding of how SARS-CoV-2 is transmitted, and also groups looking at the animal-human interface at the origins of the virus, and then epidemiology, clinical presentation, etc. So all of that coordinated by the WHO, but obviously work going on all over the world. What's also relevant is that we set up the ACT Accelerator way back in April 2020, essentially with a view to bring global health institutions together to both accelerate the development of new products, like we brought CEPI, we brought Gavi, Unitate, the Global Fund, the Wellcome Trust, the Gates Foundation, Unitate, FIND, all have their own mandates, but came together to say, we need to work together for COVID, because not only do we need to invest in upstream development, but also in equitable access, procurement, distribution, etc. So within a year, of course, we know that science really delivered on whether it was diagnostics, whether it was vaccines, huge number of different platforms, novel platforms, etc. But also treatments now, I think, making progress on oral antivirals. But we were also looking at things like oxygen, and it's incredible that we've seen the oxygen shortages, but it exposed an underlying problem in many countries of not having oxygen in many district hospitals, etc., to even treat normal pneumonias that would come in there. So this is one of those examples of the pandemic actually highlighting chronic problems within the health system. And then we had, as part of the ACT Accelerator, we had the vaccines, diagnostics, and therapeutics pillars, but then you had a cross-cutting pillar, which was health systems strengthening. And that is actually receiving more attention now, as it's becoming obvious that without the manpower, without the infrastructure, without the commodities, without governance, without financing of the health system, that just delivering products into countries is not going to help. But we know that equitable access is not the scientific advances in terms of actually developing these products. And I think everyone heard the Secretary General basically putting a plea at the UN General Assembly to say that, to appeal and he made the observation that science has delivered, but ethics has not, and appealed to all to work in global solidarity. The WHO has put out some interim targets to achieve vaccination coverage, 10% of the population of every country by the end of September. 56 countries actually missed that target. They could not get to 10%. The next target is 40% by the end of December, and then 70% of the population of every country, which is essentially all adults and adolescents in many countries, by the middle of 2022. this can obviously, it's possible to make it happen because we have enough vaccine manufacturing going on now. Understand 1.5 billion doses are being manufactured every month. So that is more than enough to meet these targets if equitably distributed. And what I understand is that today, 3 times more doses are going into booster shots in high-income countries than are going into primary vaccination. So that's where the inequity really lies. And if you look at the targets that I talked about, we could have achieved the 10% target by May of this year if the available global supply could have been equitably distributed. And we could have achieved the 40% target by September. And by the end of the year, it's expected that 11 billion doses of vaccine would have been manufactured. These are estimates from Affinity, and they work closely with manufacturers. So 11 billion doses is enough to vaccinate all adults fully. But we know that we're going to be very far away, and that we even have a list of countries that may not even achieve 10% by the end of the year. So this is the supply. The equitable distribution of supplies is an issue, but also some countries need support. They need, their health systems are already weak. They don't have additional manpower. So you need to support them to bring in that additional manpower for the training, for the cold chain. For the mRNA vaccines, we've had to procure and distribute cold chain equipment to many countries. You need, additional health workforce. We've seen that essential health services were hit in most countries in 2020. They recovered a little bit, but again in 21, because of the Delta surge in many countries. Delta, by the way, accounts today for 98 to 99% of all sequences worldwide, except in Latin America, where the Gamma variant is still about 7 to 8%. But in all other regions, it's more or less Delta everywhere. So, so because of the Delta surge in 21, we've again had disruptions of essential health services. So the TB report, for example, just came out a few days ago, showing that for the first time in decades, we've seen an increase in TB mortality. In 2020, a reduction in TB notifications, significant reduction, 5.8 million versus 7.1 million the previous year, and reductions in people going on preventive therapy. So we've seen disruptions in HIV treatment and cancer treatment, NCDs, essential surgeries, and everything. So immunization, routine immunization as well. So this is a real problem, especially for countries which already have pretty, not very resilient or strong health systems. We know that the pandemic is not over, that we are hoping that we get to a place where at least we can reduce the number of deaths. But I just told you, we still have 45 to 50,000 deaths occurring every week. And so this is still a very significant amount. And we know the majority of these deaths are occurring in unvaccinated people everywhere. So even in countries which have supplies, the deaths are mostly occurring in unvaccinated. So then, of course, there are issues of also vaccine hesitancy and work on the demand side that needs to be done side by side with the work on the supply side. What are the unknowns? A new variant is the biggest unknown. If there were to be a new variant which is more transmissible than Delta and had some properties again of being able to evade immunity, then that would be very dangerous, because that could start everywhere. And so that's one reason why we need to stop transmission by increasing vaccine coverage to ensure that we don't get more variants. The others, of course, is that there's a two-track pandemic. High-income countries getting back to normal. If you look at Europe now, in many countries, life is pretty much back to normal. But in large parts of the world, of course, this is not. And if the vaccine inequity continues, it's estimated that another 5 million lives could be lost in 2022, and a 5.3 trillion economic cost by 2026 is what the IMF has predicted. Before I close, the On the diagnostics also, I mentioned that there were inequities. And so we have goals. The ACT Accelerator has goals of getting to, I mentioned the 70% target for vaccines by the middle of next year, 100 tests per 100,000 population per day for diagnostics. And for treatments, again, there is an aim to treat 120 million people, mainly in low and low middle income countries, especially now that, we have it's looking like we will have oral antivirals, because the monoclonal antibodies were certainly very difficult to administer and also very expensive. And also PPE. So PPE was a big issue right at the beginning of the pandemic, but obviously healthcare workers continue to need protective equipment. So perhaps I will stop there, Neil, and see if there are any clarifications or questions for me.
Perhaps we'll ask the panel if they want to ask you anything. I think because you have to leave early, we'll do things in a little bit of a different order, but otherwise we'll be moving on to Zen. Did anybody who wants to comment on anything from the panel itself? Okay.
I guess the one thing I would like to ask, and we've talked a lot about the global access to vaccines, and there's obviously a recurring theme. As we start talking about novel therapies, some of them are incredibly difficult, but the molnupiravir is the one that came up in terms of global access, and it would be an incredible feat, obviously, to have this available as a mitigation measure for delicate healthcare systems, and even for things like oxygen stewardship. What do you foresee in terms of access to, or equitable global access to, even oral therapies for COVID-19 as they come through the pipeline, and how do we kind of ensure that moving forward?
Yes, so that's a good question. And, going by past experience, it's likely that deals have already been made to book. We know some countries have already paid upfront, to book certain number of millions of courses. The good thing is that with small molecules, it's easier to quickly do the tech transfer and the scale up manufacturing. So for molnupiravir, for example, we know that Merck has already entered into voluntary licensing agreement with a number of Indian generic manufacturers who are already in advanced stages of producing the drug, and that they're also talking to the medicines patent pool to do further transfer of technology. So I think that's very promising, and if that's a kind of approach that all companies should take from an early stage. In fact, we spoke to many of the manufacturers of the monoclonal antibodies, and also Roche, for example, for the IL-6 inhibitors, but there's been less success, partly reluctance on the part of the innovator, but also there's also limited capacity for biologics in terms of generic manufacturing, and that's something we would like to see strengthened in the years to come for the future.
Yeah. Oh, thank you, Soumya. As I said, Soumya is going to have to leave very soon, but I've got to say, what I appreciate about her is that she's not just a clinician and a scientist, but she's also indirectly an advocate. And the way that we connected about 10 years ago through her father, but we reconnected as she was viewing the situation in our homeland of India and South Asia back in April, and trying to see what we might be able to do. And so she ended up looking at some mentorship along with Echo India of physicians in different parts of India and in Nepal. And so we got connected there. And the reason that I'm also mentioning this is that this is where I got in touch with our next panelist, Dr. Zen Chugla, that he was considered to be the expert in Canada that we should get as an ID expert to help with telementoring in Nepal. And I only found out later that he's one of my nephew's best friends. But Zen is an infectious disease specialist and now a media star on COVID-19. I see him on all of the national Canadian media. He's published many op-eds on testing, public health interventions, and disease elimination. During the COVID-19 crisis, he's contributed to local, provincial, and federal policy planning and to several clinical trials on COVID-19 therapies. He's published his works on COVID, epidemiology testing, and infection control. Zain's an associate professor at McMaster University. He also has a master's of science in ID and a diploma from the London School of Hygiene and Tropical Medicine. So Zain's going to be talking a little bit more about the pandemic in Canada, a bit about vaccines, social distancing, passports, prospects for the future, issues involving immunization of children, a bit more on evolution of variants and getting vaccines to the global south. So I think, Zain, we've got a lot for you in 5 minutes, maybe a little bit more.
Happy to be here, and thank you. It's going to be hard to obviously top that last speaker, and very happy to discuss with some esteemed panelists and colleagues that we've met through different means and methods over the last year and a half. I'm happy to just flip up my slides. I think I can flip up my slides here. Let me just slideshow here. I wanted to just quickly talk and you know, there's you're seeing my slides, right? Yeah. So just quickly talk about the situation in Canada and some subtleties, where we are, and the future. So, you know, as we are dealing with in Canada, and obviously Canada is the second biggest country on earth, has a significant number of different epidemiologic pockets in terms of the pandemic. We are now largely seeing a receding fourth wave, although not necessarily a receding fourth wave in terms of healthcare utilization, and different situations epidemiologically across the country, where some provinces have had relatively good control with high levels of vaccines and some degree of public health measures. Other provinces have unfortunately seen a fairly significant fourth wave, some of which worse than other previous waves, for, you know, the opposite of having relatively low vaccine rates as compared to the country, and high degrees of non-compliance with public health measures. And so unfortunately, there have been people that have had to be shipped to different provinces, which is, you know, thousands of kilometers in terms of distance to meet healthcare demands. But, you know, there is you know, some hope as we get to a rate of immunization of over 83% fully vaccinated across the country of eligible candidates, that we are starting to see the disease fundamentally shift into unvaccinated individuals and long-term sustainability of trying to deal with the pandemic. While these numbers are important, I think it's often important to frame who was infected with COVID-19 in Canada. And, you know, that is a story that really has not been told very well. This was our own research out of Toronto and Peel region, which is a suburb of Toronto, with a significant amount of people that are what we consider essential workers. So regardless of public health measures and lockdowns, not able to work from home, and people who, looking at their income status based on census data. And again, looking at that, this paper is embargoed, but is actually going to be published today in the Journal of the American Medical Association. And, you know, we looked really between February and March of 2021 for one specific reason, is that was the introduction of the Alpha variant into Canada, which led to our third wave. But as an aside, it actually created an interesting epidemiologic experiment into seeing, as you introduce a new variant into Canada, you know, essentially where it's going to start going first and what populations are overrepresented, to give us a better magnifying glass of what exactly happened, you know, where the pandemic has hit the worst and where chains of transmission are occurring. And so the results are not surprising. You know, when we looked at after tax income, so people who are at the lowest after-tax income as compared to the higher after-tax income, the rate of growth by prevalence by COVID-19, and particularly the rate of growth of variants of concerns in that population were the highest in the lowest income population. And the results were actually very much more striking when we looked at people who were at the highest essential work status. So people that could not work from home in manufacturing, service, retail, or other kind of front-facing positions. They were disproportionately affected by COVID-19, but also disproportionately affected by the variants of concern, particularly the Alpha variant as it emerged in Canada, which really does give us a roadmap in terms of where COVID amplification and transmission occurred in the worst. And unfortunately, our third wave in Canada was marked by these individuals, unfortunately, being hospitalized. But one of the benefits of it was that our vaccine campaign was very much targeted towards these individuals as an initial protective measure. We now are in the era of vaccine passports, and there are major equity issues associated with this. So this is the BC, British Columbia vaccine passport. There are ones now across the country. It certainly has allowed for more societal freedoms and us to reopen society in certain higher risk settings. There's been small bumps in vaccination across the country associated with them, not as profound as places like France had experienced. Certainly a slight increase in uptake, but recognizing that this wasn't necessarily the driver for people to get vaccinated. It certainly has also created tensions, and Canada and different places are starting to navigate where these what settings these could be applied to outside of the traditional restaurants, gymnasiums, sporting events, that type of thing. Does this need to be implemented in things like schooling settings? Does this need to be implemented in we're hearing now even reports of certain medical settings where people are expected to be fully vaccinated. And realistically, there is a huge ethical considerations that I think Dr. Bowman can talk about in terms of making sure that people who are unvaccinated still have access to their constitutional and fundamental freedoms that they're able to in that sense, and not to impose a mandate that's considered far too dicey as part of that. The last part, I think, around the vaccine mandates that has been interesting and unfortunate is the arrival of a Canadian election in the middle through this. So federal leadership election, including the election of a prime minister that occurred through September. While many of these passport and mandate systems were being rolled out, it unfortunately allowed for political alignment along party lines amongst their considerations of vaccine passports and mandates. And in some senses galvanized groups together that were not necessarily brought together in any other methodology, but now put a political name to them. And so it's also created an us versus them mentality in many contexts, and again has really put people together who were not linked before. Moving on to the evolution of variants, and then as Dr. Samiam has recognized, the Delta variant has essentially taken over Ontario and largely represents Canada. Its emergence was fairly profound, and it actually took over all other variants very quickly, and it extinguished lineages like P1 and the Mu variant, as well as the Beta variant. And really has now created a fundamental backbone of entirely where we are. There are sublineages that we talk about that are being reported, and again that's a part of now how we have to transition likely our molecular strategies. And I think again in the context of us using international travel as a potential mitigation measure, as travel opens up, the likelihood is, the use of travel restrictions to prevent the spread of variants is going to be much more compromised as we have individuals now traveling back and forth from basically all areas of the earth. And so again, on-site genetic surveillance is probably the biggest tool we have, not to prevent the spread of variants, but more to at least map what's happening and prepare for their spread more than anything else. And so now we face a different challenge. And so Canada was also one of the first countries to start doing youth vaccines, and much to some of the disappointment from some of the world, including myself and others, not that they were not needed, but recognizing there were a significant amount of vulnerable individuals, healthcare workers abroad, that were not getting access to vaccines altogether and still have not had access to vaccines. We are now hearing about Pfizer's submission for Health Canada for a pediatric vaccine campaign, which again is going to challenge global supply chains. Unfortunately, there is this, what's happening in our neighbors versus what's happening with us. The need for global security versus home security. And I think this is a difficult balance across all settings. So, our politicians are facing a population that's sick of the pandemic, that was told vaccines were the way out, and want to see Canadians protected as much as possible, but face difficult challenges in navigating what's ethically and morally imperative to make sure that the world is being vaccinated appropriately, even though from a public messaging standpoint, that's very difficult. And I think, unfortunately, it sounds like we're head first into a pediatric vaccine campaign too, again, to protect certain high-risk individuals. But, again, we will likely be through a pediatric vaccine campaign before, many countries reach that 40% target the World Health Organization has set. And unfortunately, much of sub-Saharan Africa will not be able to reach by the end of the year. And with that, I'm happy to take questions or hear from my esteemed colleagues here too.
So we are starting to have some questions in the Q&A, but I think I'd like to do this, address those once we finish the formal presentations, just to make sure we've heard from everybody first. Yeah, there is something there that you can read in the meantime. So for those who are attending, you can use the Q&A and we'll get to those a little bit later. Our next panelist is Dr. Carrie Bowman, whom I just heard on Cross Country Checkup. So another media star competing with Zen. Just heard him on Sunday and wrote to him, and then he said he was happy to participate. I felt that having the perspective of a bioethicist and environmentalist might be useful, although I think Carrie's experience has been more with primates who are a bit more collaborative than human beings. He teaches at U of T, holds an academic appointment with Family and Community Medicine and the School of the Environment at U of T, University of Toronto. He's also consulted with the United Nations Environment Program and contributed to the 3 global environmental outlook reports examining the connection between human health and the environment. He's has a CIHR grant, Canadian Institutes for Health Research grant, exploring the interrelationship between climate change, forest loss, and the COVID-19 pandemic. It isn't really so much the environmental side or the great ape side that we want Carrie to speak, but more on ethical frameworks in terms of global vaccine distribution and vulnerable populations that both Soumya and Zane have already started the conversation on.
And that is what I will do, Neil. Thank you. How do I forward these? Let me just see.
Yeah, it looks good.
Okay, is that forwarding? Yeah.
Yeah.
Okay, I'm going to take this from a different angle, guys. I'm not going to, you are an incredibly informed audience, and I therefore am going to talk about, I want to really talk about the big picture and what my experience has been with all of this and try and get some thoughts from people, especially in the discussion period, as how we can really focus more on the global reality. My observation is nationally, and of course I'm in Canada, but I've been snooping around on other websites and watching things from Europe and the United States and mostly high income countries. And there's a strong pattern in which most of the commentary is absolutely and almost exclusively national. It's very rare that anyone is mentioning the larger picture. Hang on, how do I scroll these? Do I just click? Whoops, what have I done there, Neil?
You'd have to do screen sharing. It's Camille, and I was screen sharing for you.
Okay, so I'll do screen share and then Pegasus share and then slideshow, right?
Yes, correct.
Okay, what happened to slideshow? Hang on, just give me a second, guys. I've got to move this far out of the way. Okay, slideshow. Slideshow from the beginning. There we go. Yeah. So what frustrates me enormously with all of this is early in the pandemic, it was very, very clear that epidemiology and humanitarian ethics converge. And that's what all of us are saying today. And you know what I mean by that. You know exactly what I mean by that. To really deal with this crisis that we've got with a global pandemic, we have to think globally. It also aligns very, very much with humanitarian ethical approaches, meaning, yes, we have concerns for our nations and the safety and well-being of our citizens, but we really have to look at the big picture. And if we're truly going to protect our people and our vulnerable people, we have to think globally. So why has this been so difficult for us to focus on? And again, if you watch the media, the amount of interviews that even touch on global questions is very, very limited. So in many nations, pandemic experts, thought leaders rarely comment on pandemic beyond their borders, and the genesis of the pandemic is rarely mentioned. And a lot of people don't really want to think about what caused this pandemic, but they really should. I was around for the first SARS. I was working in the Toronto teaching hospitals. I was actually exposed to SARS. SARS used to mean something very different. Remember that? I don't think any of you guys were around. I'm not sure, but I was even quarantined. And for me, you know, there was an incredibly frustrating element in which we knew from SARS-1 that zoonotic risk disease was elevating, particularly with wildlife markets. And we did very, very little about it. And, you know, the COVID-19 pandemic really has been an accident waiting to happen. The problem in Canada, and Zane described this really very, very well, we've really moved into what I would call the vaccine wars, and the creation of an adversarial climate, moving our thinking further away from pluralism, shared ground, problem solving, and inclusion. In Canada, we started out with a lot of dialogue about we're all in this together, which wasn't really true, but it was sort of a nice thing to hear. It never really fully accurate, but boy, have we ever moved away from that. And a huge distraction from the greatest threats, which are emerging variants and recurring infection due to global inaction. So what I have found, my observation as an ethicist, is that, most countries, most regions have been unbelievably myopic in their approach. I myself am doing a great deal of media, more than I've ever done in my life. And I'm endlessly struggling, trying to slide in as much as a comment about the global picture. And, the media is okay, but as some of you know, you've got 4 minutes, 5 minutes, maybe 6. It's very hard to get this in. But my concern is this, that and Zane, you are one of the only people in our entire country that I have heard actually tie in significantly global issues with this. I'm not saying it never happens, but it doesn't happen very often. So One of the greatest concerns that I see in high income countries is our politicians are barely interested in the global picture. They're dealing with a national thrust. And many of the epidemiological experts and what many would call thought leaders or whatever you might want to call them are focused on very national issues. So there is nothing that's actually emerging from many high income countries that are saying we have a much larger consideration here. Those voices are not happening, and it puts our politicians in a position where they're in a much better position to ignore this kind of things. The good news with this, and I speak ethically, is inequities are not just the result of what happens when systems fail. Inequities are often the result of the way systems are set up and operate. So the pandemic is really coming at a time where there's much, much more concern about systemic inequalities and social injustice. And my hope, I'm trying to be positive here, is that we really are, within a lot of Western and non-Western cultures, we really are seeing the price of structural inequities, injustice, including race, including disability, including a broad range of things. We have a living example of how these things actually work. And we're also seeing, very highly authoritative governments. We're seeing crystal clear, whether it be the United States or Brazil, what the kind of results can be from a pandemic point of view. So that's a strength. So we've learned vulnerability and equity, yet few global lessons. The pandemic's made it clear that questions of justice and equality are severely amplified by profound structural inequalities within society, and pandemic health outcomes are grounded in pre-existing systemic disadvantages and how social justice demands greater attention. Lessons learned are almost all national and very few global. So I've spoken to some of my colleagues about this, and guys, I don't have a perfect answer for any of this, so it's something I very much want to discuss. My colleagues being people in Toronto teaching hospitals and Canadian universities, and they say something that's really quite fair. What they are saying is, I am not qualified to talk globally. A colleague of mine said to me yesterday, this surprised me a little bit, but he said, I've never even been to a middle income or a low income country in my life, he said. And look, he's being fair, right? He's saying, I'm not qualified to look at the big picture. And that is really tough when these are the very people that are speaking out in relation to the pandemic and next steps. If their awareness of global issues is really at that level, they are certainly not going to be talking about it. And I do feel that the global message in the media has been profoundly weak. And the pandemic has been very much media driven, as I think a lot of us have experienced. Waiting for literature, waiting for peer reviewed publications, it's going to take time. And many of us, when we get up in the morning, maybe this is more true of me than you, I don't know, but I'm scanning the websites from a very, very early hour to see what is going on. So that is one of the great changes. So the other thing that concerns me is the way we frame the problem will enormously affect the outcome of the pandemic, as well as how we respond to future threats. So globally, the language tends to be pathogens are being deemed primarily as global security threats, almost from a military kind of structure that may trigger many interventions, some of them good. Yet that kind of a focus on global security threats really does limit more careful attention to the social, economic, environmental, and political drivers in which disease outbreaks occur. So that is of great concern. And I won't go on too far with this, but I can tell you a lot of my work has been related to emerging zoonotic infections. I was actually in the Wuhan market before the outbreak. I counted 56 different species of animals, 2/3 of which were wild species, 1/3 of which was domestic. I've spent a lot of time in the wildlife markets of Africa, the Amazon as well in South America. And this great threat of zoonotic disease is absolutely not on the radar. And when we do talk about the future, and I'm jumping ahead a little bit, most of the interventions people talk about are surveillance. That's kind of what we do in medicine in the first place. We watch for illness rather than prevent it. So how do we have global surveillance for the next pandemic? where I would argue we have to go much further upstream and look at what is actually going on in this world. So the essence of what I'm trying to get to today, guys, and I guess we can't really call this much of a framework, is how do we continue to draw global, national attention to a global level? Because the presentations today have been very clear. You know, people may die. We could lose another 5 million people if in fact we're not able to focus more. As Zane quite clearly said, you know, Canada and many other nations, including the United States, will quickly focus on pediatric immunization, and we're falling behind on the global focus. This has ethical problems and it's got epidemiological problems. You know, flying over Brazil, I mean, you can say, you all know about zoonosis. You can see the massive amount of environmental changes and how so many of these drivers are really significant in this type of thing. And, you know, again, I'm here in Brazil, you can see the interface of social inequalities, favela on the right, high income, favela on the left, high income on the right. So these are the kinds of things. It's also such a shame that it's now reached the point where this COVID-19 pandemic, look, I don't know the original cause. I know what I've read, but the fact that more and more of the general public are rejecting the possibility that this is animal-based, and many people, I see it in Canada, I see it in the United States, to a lesser extent in Europe, have very fixed opinions on China, and nothing is going to change their mind. They see China as absolutely demonic. And you know, this is going to be a huge barrier from a global health point of view in the future if we cannot really even begin to get to the core of the genesis of COVID-19. Let me stop there because we've got multiple speakers.
Thanks, Kerry. You know, that's great to have a bit of more global perspective, not just on ethics, but also including human beings in this Anthropocene, but also thinking about our effect on the environment and the environment's effect on us. So our next speaker is Dr. Camilla Janella, who has a PhD in psychology from the University of Bergen, a master's in global health from Charité Universitätsmedizin in Berlin, and a degree in psychology from the Pontificia Universidad Católica del Perú, where she's currently the executive director of the Center for Social Sciences Research and an assistant professor in the Faculty of Psychology. She's also a researcher at the Nicholson Institute and global fellow at the Center on Law and Social Transformation in Bergen. Camilla actually, it was a replacement of another speaker, but our other person, Maria Elena Planas, also from Peru, said, well, with the themes that we wanted to talk about, Camilla was the expert. And we asked Camilla to talk a little bit more as a social scientist and psychologist, perhaps, but talking about more why Peru was at higher risk, what happened particularly in the first wave, issues around vaccine distribution in Peru, and current issues with vaccines in South America. And I think that this, with Peru being one of the most affected, if not the most affected country in the world, I think it's very, very timely to think about these issues. So thanks, Camilla, for doing this in the last few days.
Thank you for the invitation. This is really nice to be here and to have the opportunity to share with you. Okay, so I want to speak about Peru. As Neil already said, we are one of the countries with the highest mortality rate per capita. The first wave was awful last year, but this year was the second wave was hit harder the entire country. So I think that is something to take into consideration. And also, I mean, by different of what happened in other countries in the region, as Brazil or Nicaragua or even Mexico, In Peru, we comply. We in early, like in March 2020, when with the first cases and no deaths, we're starting taking the recommendations that the World Health Organization gave on restrictions, on trying to control the disease, and we failed. We failed with a lot of success in a way. But the thing is that we kept this restriction for a long period, no? So just now in October, it has been, most of these restrictions has been removed now that the vaccination has been in place for many months. But there are some restrictions that are still there. So schools are still closed. Most of the schools are still closed. There is a plan to return, but it seems that we are going to start really with most of the schools by for the next 2022. And we are still dealing with the pandemic and the economy impact that pandemic has had in the country. Why this happened in Peru? I think there are many reasons. There are reasons related with the health system capacity, and this is important to. We have been speaking about the political and determinants and the political determinants of health, and I think that Peru was, by you read newspapers and look for Peru beginning of 2020, it was the rising star. The economy was growing. We have like 30 years of continuous economic growth, but still we were not investing enough in the health system. And that is something that the pandemic unveiled, no? And I think that put us in a worse situation that our neighbor countries like Colombia, Chile, or even Brazil. We didn't have the information system that, for example, Colombia had in place, so they were able to detect quickly the cases and to take decisions based on the information. We didn't have that. Our surveillance system was super weak. And also we didn't have the network of laboratories that other countries in the region have. So we were really in the worst situation on that because of the lack of investment on public health, as has been for many years. So we knew that we were facing a shortage in health workers, and also our health facilities were not in a good shape. So that means that the Minister of Health decided to shut down the primary health facilities, health posts, health centers, and only keep the more complex ones, like working with COVID. And that has had an awful effect on other conditions, health conditions, and just regular care. So maternal mortality has been also going up. Cancer, tuberculosis has been deeply affected, and that is something that we have to take also into consideration, how this has been affecting the non-COVID services. On vaccination, I think it's also important to try to understand the political side of this. We were late on the negotiations because we have a huge economic crisis in November 2020 with change of government, a transitional government that only was in place for 5 days with a lot of protests, riots, and that made us to lose key days. But Peru was also, and I don't know how many of you remember that because this has been crazy times, but the case of the vacuna gate, that is not the same that happened in other countries in the region when you have some politicians that were just jumping the line to get the shots before than the population. The vacuna gate is the case that where the team of researchers at one of the most prestigious universities in Peru that was in charge of the Sinopharm clinical trial got some candidates to the vaccine and inoculate key officials, including the former president Martin Vizcarra and the research team, but also all the some key officials that were involved in the negotiation of the vaccines. So this created a lot of suspicions about the Sinopharm vaccine and in general about the vaccination campaign, and that has affected a lot the trust on the vaccines here in Peru. The other thing that has been playing a bad negative impact is this idea that there is in Peru and of that the thing has to be private and the private sector is going to make it better than the public. And in general, that this is a really segmented population. So when we started with the vaccination of the population, we started with segmentation. So in April, when we started to vaccinate the elderly, March, April, this was segmented by profession, more or less, and if you have access to official formal work. And this was bad. We were out like trying to say that this was wrong. This was the wrong approach to make this segmentation of the vaccine, that we need to just to vaccine the whole population independently of the insurance status. And that is the approach that the minister at the end took in May. And I think that allowed us to go ahead. Nowadays, we start have some big disparities on the distribution of the vaccine. There are some regions that have achieved a high coverage, like more in the coast with urban areas, and less in some regions that with more rural population, and regions that were and some spots also of the population that have a high distrust in the vaccines. The plan is to have 50% of the target population vaccinated by end of this month. I think that is possible, but with huge disparities. So you're going to have some regions that they have 20% and some regions that have 70%. And we need to think on that, what that means. And we have started with the third dose to health workers, that they were the first to be vaccinated in February, but now they were asking for a third shot, and they have been, we started with that. Again, we are not at the same level that other countries in the region, but we are going in that direction. And Mexico, Brazil, Colombia, Argentina, they started before than us. We struggled at the beginning to start, but when we started, I think we has been going okay. But there is still some huge inequalities that also are linked with the access to healthcare, especially in rural areas, in the Amazon area, and also with all this campaign against vaccines that unfortunately was fueled by the vacuna gate. And I think that then the academia has to be more, to reflect more on what is our role when we are involved in this kind of research and scandals. Yeah, that's what I want to share with you. Thank you.
Yeah, thank you, Camila. No, that's great. And I know I've been giving the panelists so many topics to manage, and then I say do it in about 5 minutes. And of course, we're taking a bit longer. I think what we'll do, we've got 3 more panelists, but what we'll do after we finish from the panelists is actually open it up and even give people in as attendees the mic too, if they want. So we'll make it much more democratic as an opening. I see that we have our newly elected Green Member of Parliament, Mike Maurice here, and an environmental studies professor. So we have a lot of expertise amongst the attendees. So I think that we may end up just having people voice their questions later once we hear from our last 3 panelists. So as I said, from hearing about Peru and issues of equity within the country, as well as we've talked about more issues between countries. Now we have Yogesh Chaudhary, Yogi got up at 5 in the morning in the Solomon Islands to be with us. So I wanted to give him a bit of time to wake up before he was going to present. He's a medical doctor with a master's in preventive and social medicine from India and a master's in public health from Israel, working in public health for the last 30 years, being a consultant around the world on a variety of public health issues, from communicable diseases, HIV/AIDS, STIs, polio, TB, and emerging infections, and then influenza. He's been instrumental in healthcare reforms in India, and even in terms of the IHR, the National Health Regulations. I think I got the wrong acronym back in 2005, more globally, work on pandemic H1N1, and then finally with SARS and COVID-19. He contributed to the process that developed the Public Health Agency in Canada after SARS in 2003. Currently, he's working as a senior advisor to the Ministry of Health in the Solomon Islands. Really, what I wanted Yogi to speak about is the Solomon Islands now, for I think a country of almost 1 million people, has 20 cases of COVID, 20, and none locally transmitted, which really gives it the lowest case count in the world. And with Yogi having led a lot of this, I'd like to hear a bit more about the strategies that they have and what they're looking at as countries like New Zealand, which were aiming for a strategy of elimination, move to containment, and then issues about immunization within the Solomons and recommendations for other countries in the global south. So thank you, Yogi, for joining us.
Hello, good morning or afternoon, everyone. Can you hear me?
Yep.
Okay, great. All right. So thanks, Neil, for the invite, and it's a pleasure to be a part of this this August gathering here. I'll share some experiences on Solomon Islands in particular. Solomon Islands is a Pacific island nation with a population of close to 720,000 people spread all along the different islands, some very remote. So when this COVID issue started to happen in January last year, I would say we have had a little bit of more experience in terms of doing business because of the measles outbreak that was happening in Pacifics and in the neighboring countries in November of 2019. So we tried to put in some public health measures to prevent the entry of measles virus, as well as to respond locally to the measles outbreak in case it happens. So I think like we were severely limited by the law. But some of the key points that have emerged in our response to the COVID-19, as Neil mentioned, we have had 20 cases in Solomon Islands. They were all imported, and they were all detected in quarantine and released from the quarantine. That's sorry about that, but that's the reality here. Okay, the backgrounds that you see here. We live in nature, Kerry. We live very much close to what. Let me just close the door and come back. It's the street dogs, a lot of street dogs here. Okay, so anyway, coming back to, so we had 20 imported cases in Solomon Islands, all detected in quarantine stations, and they were released after having been tested negative. So we had our first case way back in October 2020. So that was 9 months when we were into the mid of the pandemic. Our policy was very clear that we have to prevent the entry of the virus and we had put in border restrictions. I will not say that we closed the borders. The people were still coming in, cargoes were still coming in, ships were still coming in, but we had restriction on who can come into the country. And one of the things that happened here was very high level engagement of the Prime Minister office. We established an oversight committee at the level of the Prime Minister, led by is chaired by the Secretary to the Cabinet. And it's all the deputy ministers, rank people, we call them permanent secretaries. They are a part of it, and we have been meeting without fail every week since last year, February. So I'll say it was a whole of government approach. And then we had in terms of whole of society approach, we invited the church leaders and the village chiefs. So we are in constant touch with them. We are talking to them in terms of response. Look, what I see here in Solomon or in the world, that may be my thinking. It's a largely health issue, but it's not completely a health issue. It's got a lot of other dimensions, social, economic dimensions to it. So we really need to have come together to address the pandemic. So that is the approach that we have taken in the past with us. In terms of leadership, I think a strong leadership and the establishment of this oversight committee, we have had a unified messaging coming from the top, disseminated to our risk communication partners, including churches, including village chiefs. So there's a unified message that is going on. And I do have concerns about how we have managed the international scientific information in terms of preprint and, people trying to throw in the studies in your face because they think that there's something important, but it sends very wrong messages to the people here in Solomon Islands and maybe other countries where people depend largely upon the publicly available information in terms of science. So a very unified approach in terms of communicating with the people. In terms of medical response, I'd say that just to let you know that we don't even have a CAT scan machine in the country. Okay, we don't have even a single intensive care unit bed in the country, not even a single finished. Okay, we never had a qPCR until last year when in May, the donors have given us the WHO and the PRC, People's Republic of China donated us a qPCR and we had to establish a lab. We have a very limited testing capacity. We can only do 200 tests in a day. Okay, so we had to take measures to prevent the entry and prevent further spread. We were one of the first countries, I recall, that we instituted the pre-arrival testing. And when you are in the quarantine, you are tested 3 times, whether you have symptoms or you don't have symptoms, 2 or 3 times, depending on which countries you are coming from. Like every person that comes in the country undergoes a risk assessment by our risk assessment team. So we take a decision on whether the person, how many times the person is to be tested, what would be the quarantine period for this particular person. In terms of shipping, which is another possible source of bringing in the infection, we have a vessel exemption committee. We depend a lot on the cargo to come in, and the ships are constantly coming in, including logging ship, cargo ships, oil ships. In the last 5 months, we have detected 15 cases, approximately 15 COVID cases on ships. And because of our testing policies on the ships, we have been able to prevent the infection from coming in. Like our stevedores go and work on those ships. So we take this precaution that every ship that is coming in also undergoes a risk assessment and proper testing is done on the ships. So that's in terms of prevention, we would say. It has definitely affected the economy. There have been talks to kickstart the economy back and open borders more frequently, more openly. especially when we see countries like our neighboring countries like Fiji and Australia are starting to do so. We depend a lot on tourism, which is virtually zero in the last 1.5 years or 2 years. Then other things is that our approach now is, and Dr. Soumya mentioned about this thing, we are moving towards a health system strengthening approach. Our clinics don't have doctors, no internet as in Peru that she says, actually no power supply, no running waters. You know, most of our clinics are like that. So we are building into a health systems approach. And the COVID response would largely be now, previously we talked about community engagement. Now we are talking about community led. And we've got some very good examples in our Western border communities where we set up the community task force. So there have been illegal movement between Bougainville and Solomon Islands because of the social as well as economic reasons, which we couldn't control. So we set up the community level task force in each community. So if there's an illegal movement that happens, they put the people in quarantine and isolation. So now we are going to every community and establishing the quarantine and isolation spaces. Look, the government cannot handle quarantine and isolation. We don't have resources. If I have to quarantine 300 people at one point of time, the houses, home quarantine doesn't work here. The houses are not designed for community for quarantine. We have big families in the houses, so we have to identify community quarantine spaces and isolation spaces, which are being managed by the community itself now. So we've got some great examples in our Western borders on that. So in the next 1 year, our focus would be, of course, will be on vaccination, but also strengthening the communities to respond to this thing. We have been working on that, but I think the major focus now will move to the community. In terms of immunization, well, I don't know whether I'm the right person to talk about immunization because our rates are, we started immunizing in March. And our rates right now is close to 40% of the people in Solomon Islands have received either 1 or 2 doses, like 10% people have been fully vaccinated. So the approach that we have taken, and here I would little bit beg to differ with the recommendations, or I think like we were under kind of pressure that you have to start immunizing the people who are 55 and above, comorbidities, essential workers. So we took a different approach, which was an outbreak based approach. So we knew that illegal movement was happening in Western border. So we started vaccinating the entire population in the vaccine at the Western border, because that is where we were expecting that the outbreak would happen. And we have had some movements of HIV for COVID positive people across the borders. So that's the approach that we are taking. And also in terms of now our current policy is to vaccinate everyone 18 and above, because we only have AstraZeneca and Sinopharm vaccine. If we get Pfizer next month, we'll be focusing on 12 to 18 and pregnant women. In terms of vaccination coverage, it's in the pockets. For example, in the Western border, people could see the likelihood of infection coming. So our population, the vaccination coverage is close to 90 to 95%, versus in places where they don't see the threat, the vaccine uptake is really low. But that's the situation that happened in Fiji. Fiji also started the vaccination in March, and the uptake was very slow to start with. But the moment the community transmission happened, now they have a vaccination coverage of close to 97 or 98% with first dose and 70% with second dose. So that's, I think, like we are moving around along with the outbreak pandemic, and getting our systems ready, getting our communities ready. It's an ongoing process. It's not going to stop. We have to live with it for the next few years. Vaccine is great, that we have to do vaccination to prevent severe disease and deaths, but also we have to see the science that people have started third dose, booster doses, how long the antibodies to the vaccine they last. So all these things are coming up. We have based our response totally on science. So that is what I'm saying. And we have got great support from the Prime Minister office, and politicians have come together in a unified way, unified voice to respond to the outbreak. Thank you. I'll stop here. Happy to take questions later on.
Yeah, thanks, Yogi. Yeah, we've got very little time, so I'm going to try to get to our last two speakers very quickly. So Srinivas Murthy, a clinical associate professor in the Department of Pediatrics at the University of British Columbia, and the Health Research Foundation of Innovative Medicines Canada Chair in Pandemic Preparedness Research. And so Srinivas has been very active in terms of advocacy for more fair distribution of the vaccines, and he'll be talking about approaches in high-income countries with regard to boosters, a bit about COVAX and the compulsory licensure debate, and perhaps lessons from HIV. So a lot again in 5 minutes.
Yeah, thank you for that, Neil. Thank you, everyone. It's great to be here. 5 minutes is a quick time to talk about that whirlwind tour. So I am not using slides, and I'll just sort of speak about some of these sort of high-level issues, because I think they touch on a lot of the stuff that people previous to me have already spoken about. And so I'll take things in turn, let's say. I'll take your first comment was on boosters, and I think that's a fundamental conversation that our country and our world is having right now. I can wear my epidemiology clinical trialist hat and say we need more evidence. I can wear my political hat and say it's good to get these doses out to the right amounts of people to make sure that people have sort of confidence in their government. And I can wear my equitable access hat in solving this pandemic and making sure that we have as many doses out to the world as possible, as Dr. Swaminathan highlighted at the very beginning of this session. So as I think about marginal benefit of a third dose in a Canadian, regardless of their risk status, versus the marginal benefit of a first dose in a healthcare worker in a low-income country, or an immunocompromised individual in a low-income country, and so on, then you have to reflect on where we think the priorities should be as we hope to sort of solve this pandemic. And then it sort of speaks to what our priorities are in this pandemic response. Are they to save lives, and are they lives globally? Are they lives in our community? Or are they sort of return back to normal and get our sort of economy back up to speed and go back to the movies and so on? And I think as we sort of wrestle with these things, both at the regional, national, international levels, these are sort of complicated questions that we haven't answered yet. And our default is, as Carrie went into the beginning, is to resort to nationalism and nativism and hoard as much as possible without thinking about the global and more sort of larger picture. And so boosters are part of that conversation. And I think I'm glad that we're having them again. But remember, we should have had these conversations last spring when we knew that these vaccines were going to be scarce and we needed to have a sustainable and sort of clear path as to how to distribute them. Remember that India and South Africa back in August of 2020 asked the World Trade Organization, please, can we have these patents for these vaccines waived so that we can manufacture these products and have control on how they're distributed? And the World Trade Organization said, yeah, maybe that's not a bad idea. Let's talk about it. And it is currently what, October 2021, 13 months after the fact, and they have yet to actually come to any sort of conclusion and continue to dither on this very highly important conversation. And Canada is probably the most guilty there because they wear their traditional, let's try and solve this problem together, but not actually doing anything and remaining beholden to the powers that be to ensure that Canadians get first access to all of the vaccines. And so in the meantime, the main argument against the IP waivers are that, wait a second, it's going to take a long time to waive this technology. We can't do it. It's not going to be the solution. We should resort to the current supply chain that's there. And that's possibly true. The supply chain will emerge from Pfizer, Moderna, and so on. But remember, they asked a year ago. And they asked, and if that was waived a year ago or sometime like that, we would have had those vaccines available now, and we would have had less deaths around the world. And so that speaks to, I guess, the allocation part of the conversation, which is the COVAX scheme. And I have, I think, a minute and a half left to try and explain COVAX, which is not straightforward, but it's a global allocation mechanism that was designed back in March of 2020. It was designed to be a universal program. So all countries, all vaccines participate. Allocation based on need, allocation based on global priority setting. And yes, countries in rich parts of the world said, good job, that sounds wonderful, but you know what, we're going to participate in that, but we're also going to buy all the vaccines at a higher price so that COVAX can't actually get any vaccines to distribute. And so that's what Canada did, that's what the United States did. They'll throw a few dollars and a few vaccines towards COVAX, but in the end, take most of the vaccines first so that COVAX is left dealing with the scraps. And then you don't really have the capacity to actually control these vaccines and how to allocate them in terms of their actual manufacturer, which is what many countries around the world are calling for. And so remember, what we need now is not charity, but we need justice, and that's what every country around the world is asking for. And Canada is blocking that specifically, while resorting to charity and claiming that they're doing their part for the world. And the last part you talked about is compulsory licensing and sort of lessons from HIV. This is not a new game. This has been part of the sort of global access to medicines beat for the past 30, 40 years, whereby the claim that poor countries, quote unquote, can't make complicated things has always been the argument for the rich countries to sell it to them at a sort of discounted price and claim that that's the solution. Back in the mid 80s, Merck, I believe, said that they couldn't make Pneumovax vaccine in India. And then India decided, you know what, we're going to do it anyway. And so they made it and are the biggest manufacturer of that component product. Early 2000s, HIV medicines, most of the rich companies in the rich world said, you know what, they can't make it. They don't know what they're doing. And they just decided to do it through some complicated mechanisms and eventually got the ability to make it, and now they are the suppliers to the world and supplying HIV medicines to the world. And so these constant arguments that we're hearing about the only capacity to make these vaccines retains within a few people and a few companies, and the rest of the world cannot, has led to all of these deaths that we're seeing currently. And I think it's a policy move that Canada, and I'm glad to see there's an MP on this call, Mike Morris. I'm glad to see that you're here to hear these words. It's important that Canada really speaks loudly about how it's blocking global access to vaccines. I'll stop there.
Thanks again, Srinivas. Yeah, and it's nice to have a challenge to some of our audience here, and we'll get Mike involved in the discussion. I should add our panel is starting to look more like a manel, but it's not because of us here that Camila also had to leave, just like Somia. So Divya, you're holding up this for 50% of the world here. So Divya is a third-year medical student at Western University, and she's going to talk about the student response that she had led amongst medical students. So just a way of dealing with the issues. So I'll let you go ahead with that then, Divya.
Hi, everyone. I'm just going to share my screen, a couple of slides. So I just want to start off with, I am not an expert. I come from sort of the position of a concerned citizen. And it wasn't actually just me that led this effort. I couldn't have done this without my colleagues who were kind of instrumental in making this happen. And so I just wanted to thank Neha, Gopika, Harsh, Brinda, Ayushi, and then the list goes on. I'm just gonna quickly share my screen. There we go, okay. So essentially, kind of as a group of concerned citizens and learners, some medical students got together to write an open letter in April requesting the Canadian government to sort of sign on to the following 3 asks. And I think Dr. Murthy did a really good job of like setting up the stage of what the TRIPS waiver and what COVAX is. And so essentially the first kind of request that we had was to sign on to India and South Africa's proposal under the WTO TRIPS waiver to waive these obligations. And then the second was to endorse the CTAP technology access pool to accelerate the scale up of manufacturing and removing global barriers to access. As you know, some people kind of argue that just waiving sort of the TRIPS agreement isn't enough, and you actually need to kind of endorse technology transfer and providing the manufacturing ability for people to actually produce these vaccines. And then the third is to leverage our diplomatic relations to lead global partnerships in supporting the TRIPS, in supporting kind of waiving the TRIPS waiver and lifting any bans globally on the export of materials that are necessary to vaccine production. And I think our sentiment was, many of us were from countries that did not have adequate access to vaccination. And I think seeing that devastation and that toll, and remembering that a lot of citizens that are in Canada belong to the greater global community, and also the fact that the pandemic has really highlighted how inextricably linked we all are, despite also the rise, as we've talked about, in sort of nationalistic tendencies. We're actually all kind of interlinked in this, and that I think as healthcare professionals, or future healthcare professionals, we really entered the profession believing that sort of every human life was indispensable and worth saving. So really coming at this from, I think, the youth and belief in sort of this global equity and solidarity that the Canadian government needed to show. And so our advocacy efforts kind of involved us connecting with some key stakeholders, whether that be policymakers, NGOs, scientists, and physicians, as well as engaging the general public. Even though it started as a medical student initiative, we actually had a lot of student organizations and sort of individuals that were just interested in signing on in the community. And so it was really nice to kind of both have that education piece and also kind of show that, this isn't just 20 students that care. These are actually over 1,000 people that want to see kind of Canada show global solidarity through action and not just words. And so we just wanted to highlight the impact. So we had over 1,000 health profession students sign, along with graduate students, professionals, and generally concerned citizens. We also managed to connect with senators. Senator Umidvar was Ratna Umidvar was instrumental in kind of in meeting with us. And we also had Senator Atulajan, Senator Marwa meet with us as well and actually pose a question in the Senate. We also submitted a brief to the Standing Committee on International Trade with our asks. And we were featured on a variety of news outlets, Rosemary Barton, CBC National, and also CBC Radio. So we did actually have a lot of impact through, I guess, our collective voice. And so the takeaways, I think, on the bright side is that there is some collective power in youth voices. And I think as even just general citizens, I'm not an expert, but coming from a learner and just a youth that's entering a profession focused on human health, there is power in kind of galvanizing together and standing in solidarity. And then, I mean, the bleak is that I don't know how much our efforts have paid off, in the sense that the Canadian government's stance is still ambivalent. We will participate in discussions, but I think what it has shown is that this is an issue that the general Canadian citizen and Canadian youth care about and want to see action on. So I'll just end with that.
Perfect. Well, thank you to all of our panel. And now we've just got a few minutes for discussion. So we'll also include the couple of members of the attendees who people have wanted Mike to say something, but Mary Louise, maybe you could begin with your questions and we'll get the panels to address those as they see fit, but introduce yourself too beforehand to people in terms of your background.
Sure. I'm Mary Louise McAllister. I'm a retired professor from the Faculty of Environment. I'm interested in the intersection of healthy communities, healthy policy, and obviously very interested in what people had to say here today. And I want to thank everyone because I found it a real privilege to listen to such thoughtful and knowledgeable people. I'd really much prefer to be reading about these discussions in this kind of informed way on the front pages of major news outlets and social media than what is contained there now. And I think that's part of the problem. I think that last presentation actually did address my third question, and I didn't want to monopolize things, but I had a heck of a lot more questions. But I found it very encouraging to listen to the last presentation about the top policy steps that should be immediately prioritized to address global vaccine equity and those kinds of issues and social justice. I'm wondering if the rest of the panelists had a similar list. And I'll stop there.
So any comments from anybody here?
May I come in?
Yeah.
Okay, so in terms of vaccine equity, I would say the things are not that bad that we talk about vaccine equity. For example, I'll share the experience of Pacifics. The donors and donor partners, WHO, UNICEF, they have all come together to make sure that vaccine is available. I know in many countries it's not, but in Pacifics, we have had commitments from our donors to give vaccines. So I would say donors have stepped up. I would also like to say what Kelly said, it's the systems approach. They come with their own, sometimes with own geopolitical agendas, but in terms of, I think we've had fairly good donor supports in terms of a vaccine. The issues, when we talk about vaccines equities, also within the countries, there are operational challenges, there are issues related to supply of vaccine in remote areas of the countries. But I would say our experience has been that we have got very good donor support and support from WHO, UNICEF to have vaccine available in the country.
Okay, thanks, Sergey. Srinivas, I think I saw you nodding, so I don't know if that means you've got some comments.
Yeah, no, building on, I guess, Divya's and Dr. Yogi's piece, I think I read Divya's letter before, and I fully agree with those arguments. And I think it's a good sort of starting place for Canada. And I think I will echo the WHO and UNICEF really pushing the agenda here. And I think this is something that we can build on for future access to medicines, access to supplies, all of these things that have to change going forward, because this is sort of put everything together. That the WHO has thought that this is such an important issue to get vaccines out to the world. UNICEF has combined with them to get syringes and implementation folks to get out there. And I think moving forward for like the next pandemic or other sort of chronic diseases, we can use that sort of focus on this being a global sort of health problems, whatever it may be, and leverage this opportunity going forward.
Okay, thanks. I'm going to shift to Mary Louise's comment for Carrie. I don't know, do you feel that you can talk about social movements and global climate change? That basically Mary Louise is saying, well, it takes time for social movements to build to achieve some measure of success. Do you think the challenge here has been the lack of time for an equivalent social movement around social justice and health equity?
Time, we're almost 2 years into the pandemic, and I'm trying to be positive here, but there is social movement. And, I do see it with my students, which I feel very, very encouraged by. But the big picture in terms of our governments and our media, I don't even really blame our media, because it's such an open mic kind of situation with this pandemic. The media is just dependent on what the speakers are going to say. They're really, again, there's much more of a focus on inequities within society, but the greatest failure has been global. And what worries me is there's a much larger context to the human story, and that is the environmental deterioration and crisis we're all facing. This is kind of a small chapter of that. And, it doesn't bode well that we became so myopic in a crisis when, in fact, we've got decades ahead of an environmental crisis, and maybe more than decades, maybe hundreds of years. I don't know. So how's that for a downer of an answer? But yeah, that's kind of where I'm at with that.
Okay, well, I'm expecting, Mike, can we unmute you and maybe ask you to respond, give us something, message of hope? Mike, are you prepared to speak, or are you there?
I am here. I'm not sure about a message of hope. Rather, maybe just a message of thanks, first of all, to the Pegasus Institute for bringing together such a prolific mix. I feel like I just received a crash course here that as someone who is stepping into a role as parliamentarian, I've really appreciated. And so maybe if anything, I can ask a question of those panelists that have remained with us that are open to sharing. For myself and for others who are keen to see vaccine equity globally, what do you recommend we stay focused on? I heard WHO mentioned just recently as one example. Are there particular organizations, people that you recommend we follow along with to be getting the best source of information to stay focused on addressing? I think that statistic we saw in the last presentation that 77% have gone to high income folks around the world, that we address the inequity you've all raised, who you recommend we stay focused on to get the clarity of information. I think it was Carrie that you just finished mentioning again, that we're not seeing in the media as much as we probably should be. Who should we stay focused on to get the best possible information? And as someone who's looking to put in place policies and call this government to account, to provide some unbiased third-party information from. Thank you.
Thanks. Okay, so who would like to take that question? Srinivas?
Sure, I'll take that. And I think like the strongest group in Canada and around the world on this exact issue about access has always been MSF. They've had a very clear message. They've advocated to the government of Canada and global bodies about how to improve things with a very sort of succinct message about how to change policy to improve access based on their global experience and stakeholder consultations. And so I would suggest following that group, and I can connect you with their policy advisors in short order if required. Conflict of interest, I work with them.
Yeah, would you like to answer as an expert here? Because you've been talking to parliamentarians, but they probably ask you similar things.
Yeah, so the TRIPS waiver is the easiest thing. It's a very sort of straightforward thing that Canada can advocate for loudly at the WTO, acknowledging that you need consensus, you need the global community to sort of buy into it. But Canada, in its sort of position as a G7 country, as a sort of a large country, people look to it for advice. It can come out more strongly in that respect.
Okay, great. Thanks, Srinivas. So Divya and then Carrie.
Yeah, no, I'm going to just echo Dr. Murthy in that MSF has been doing a lot of work regarding this. That's how I sort of educated myself on what was happening. And there have been, hundreds of letters that have been MSF, like Oxfam, a lot of organizations. And then I would say like the biggest ask, at least from our collective like student voice, was the TRIPS waiver as like the first step of kind of that sharing of the technology transfer and the know-how. So
okay, thanks. Carrie. Oh, you're still muted.
Yeah, how's that? We need to encourage our governments, and the lack of, it's quite amazing in a crisis of this magnitude over a 2-year period. There's not really, there's the World Health Organization, which has been enormously, under Donald Trump, et cetera, kind of trashed and people have eroded the trust in, which I think is a wonderful organization. I would agree fully, MSF is great. But there's not a nation, there's not a single nation state that really represents the global picture. There's not even a single individual that really represents the global picture. And I think as global citizens, and some of us are Canadian, some of us are not, we somehow have to make sure that the media becomes aware and we push the kind of global voices. So Divya, I think what you're doing is amazing, and I've seen that letter before. I think we need a lot more of it. Because as so many of us have talked about, we're really caught in the weeds of vaccination wards and whether you can sit indoors or outdoors on a patio to have a glass of wine. We're really caught in the small picture and not in the big picture. And I think we have to push our politicians on that.
Great. Any other comments? Or now you also have a chance as panelists to talk to other panelists. Oh, Yogi, you've got a comment.
Yes, this whole talk about vaccine equity, I think it's a very valid talk, and we need to ensure that we talk about TRIPS, not now. I think since the days of HIV medications, so this work in progress. But this whole issue of vaccine equity does not need to be seen in isolation. We talk about overall global equity in terms of development. You can give vaccines today. So is that the end of it? Like, you have given vaccines, you have given molnupiravir or monoclonal antibodies to the world, or do you want to make the countries develop themselves? That is where I think it can set up an example, this pandemic, the vaccine equity and other access to PPEs and other things that also Sonia mentioned, which we have been getting. But I think we have to look at a broader picture, and Kerry referred to it in terms of systems approach. How do we approach the countries in terms of development and strengthening their own systems? We also know that in this, this part of the world depends a lot upon the consultants to come and work, but there was none coming here. They were all busy in their own countries to support themselves. So we have to invest into the development, system strengthening, and not take the vaccine as an example, take the other supplies as an example, but I think invest in a future strategy, have a strategy to approach the countries to be self-sustainable in times to come. Thanks.
Yeah, thanks, Yogi. Did I see your hand back up, Mary Louise? You can unmute yourself if I did.
That was a bit of an accident, but sure, I'd be happy to ask another question. I'm wondering if, obviously, we've been in this emergency mode for a while, but these kinds of emergencies do stimulate policy changes, sort of punctuated equilibrium, some might refer to it as, that does lead to major shifts in ways of thinking, either from an epidemiological study point of view, that's more my first question, or from a policy point of view, is that people start thinking about needing to shift to respond to emerging crises and so on. I'm wondering if there have been notable shifts in a positive direction, besides being lost in the weeds, as one of you suggested.
Kerry, would you like to address that?
I'm going to stop being negative for once. There really has. I mean, I have never seen so much focus on systemic, discrimination. Some of that focus was evolving. Black Lives Matter movement, social movements sort of merged with the pandemic. I think in a very positive way. There's no question that this global pandemic will lead to permanent cultural shifts. And, for us, if we can have any say in this, any influence on this, we want to make those as positive as possible. And I think within the country I'm from, Canada, I think there will. Anyone that, let's say 2 years ago, thought that social determinants of health rolled their eyes, some kind of left-wing bunk, well, think again. Watch what's happened over the last 2 years. Social determinants of health is bunk. No matter what your politics are, there's a lot of reality has hit home. And I think that's going to be very, very positive. And I think that's the good news. And I'm going to repeat what I've said so many times. Where I worry so much is the lack of focus on the global threat and the global reality and global justice. Worries me tremendously.
Thanks, Kerry. I think we're ready to conclude very shortly. Any closing remarks that people would like to make before we close the session? Srinivas, Divya, Kerry, Yogi, I think Zen is still on, but not.
From the global perspective, I want to highlight Kerry's point about this being a precursor for the climate challenge that's going to come up. And a lot of it's the same issue where solidarity around the world is required and more of a perspective outside of our own borders. And we sort of failed to do that as well as we could have. I think the lessons learned from this past year and a half applying them to climate are going to be very important.
Thank you.
Neil, I would just say I think it's been great. It's been a broad range of perspectives, and I've been taking notes and learning a lot. So I'm very appreciative to everybody.
Yeah, I just want to thank you for putting this together, and I learned a lot, and felt pretty out of water with all of these experts in the field that I really look up to, but it's been great, and I think lessons to take forward as we globally tackle climate change. And I'll say, like, I guess as like in Gen Z or the millennial generation, I think that's something that we as a generation are scared to approach, and it's something that hopefully we'll be able to kind of dismantle these structural barriers that have been pretty pervasive and seen during this pandemic.
Yeah, I think that the other panelists, Yogi, go ahead.
Just a quick word of thanks to the panelists, to audience, and Neil, especially to you. And I would share it on a very positive note. Last 3 years here, I've been on the other side of the spectrum. From donor side, we have become the recipients. But on a positive side, for the panelists, we have seen a different way of working with the donors. There'll be more interactions between the countries and the donors instead of a one-way dialogue it used to happen in the past. So I think there are definitely certain positives that we can take from here. I echo the sentiment of addressing the climate change and global climate issues. Solomon Islands and the Pacific in general are very susceptible to, we are now going to enter into the cyclone season, and I don't know how to send the vaccines to remote areas in these times. So appreciate the feedback, comments from the people and their observations. I think I learned a lot in this session. Thank you.
Thanks, Yogi. Yeah, I guess it's interesting how we put things together at the end, even in terms of other issues like climate change, other global crises, and how we react as human beings. I think you've illustrated some of the challenges in different countries, given some messages of hope. Divya, I think that many of us here feel that we're a fish out of water, not able to meet up with somebody who's been talking to Rosemary Barton and talking to various senators and organizing a petition with more than 1,000 people. So I think that all of us have really been able to learn from each other. We wanted to make this for a Pegasus Institute a time that worked for Yogi as well as Somia. So 5 in the morning for him, and for Somia it was 8 in the evening when things started. And we've had panelists who've had to leave during this time. So this wasn't the time to really get an audience. With Pegasus, we're hoping to get our audience really afterwards with our video. Not so much like a TED Talk, but we're hoping to actually look at mobilizing global action. And so, so I think that this will go beyond the people who've been part of this. And sometimes we plan projects, whether they be research or education. So we may think about that and want to involve all of you in that. And I think some of you are still involved in our institute in terms of some of the other issues around global migration, climate change, refugees. So we're hoping to keep you all engaged. So I want to thank all of you, want to thank our attendees. We found this a very stimulating discussion. We want you all to continue to advocate and live your life for the values that that you hold, and I can see that in each of you as individuals. So thank you all, and we'll say goodbye, and or it should be more like au revoir rather than adios. So we hope to see you all again very soon. Thank you very much.
Thank you, Neil.